afternoon or good evening, depending where you are in the world. I'm Jackie Druin. I'm the president of IPT-HOPE, and I'd like to warmly welcome you all to this session. It's going to be updates on head and neck cancers. It's early here. And we have the good fortune of having Liisa Laakso from Australia, who's going to be talking about photobiomodulation. We have John Davidson Okwadili from Nigeria, who's going to be talking about hospice and palliative care. And we have Gerben van Hinte, and he's going to be talking about head and neck cancers, and he's from the Netherlands. So welcome to all of you. I wanted to mention too, John Davidson's from Nigeria. So I'm going to let the speakers begin.
Okay, well. Let's see. Good morning to everybody. Let's see if my sound on. Can everybody hear me? I think that's okay, yeah? Let's see, one more time. Good morning, my name is Gerben van Hinte. I'm from the Netherlands as well. A very good and very early morning for some of you. I was asked by the supervisor of my research, my PhD research, Dr. Caroline Speksnijder, to tell you something about physical therapy and head and neck cancer, and especially on my research subject, which is more on the limitations as experienced by survivors of head and neck cancer and their unmet needs. But first, the goal of this presentation is to tell you something about the physical therapy treatment indications in this specific group, and get insight into which limitations they experience when you measure that with physical performance tests, and insight into which unmet needs these survivors themselves experience when you ask them with patient-reported outcome measurements, certain questionnaires I will tell you about. And what was our main question in this study was if the limitations as measured with these tests associate with the unmet needs as expressed by those survivors. So it would be very interesting to see if those two measure the same construct, and I'm going to tell you something about it. And the second part of my research was to see if the measurements we performed into the limitations as experienced are reliable. So the retest reliability of what you can call a bit of a core set of measurements in specifically for these survivors of head and neck cancer. A little bit of a general introduction is that a worldwide incidence of more than 650,000 cases for head and neck cancers, and a lot of deaths. The locations of head and neck cancer vary, but the main locations and the main location is the oral cavity. That includes everything from the tongue to the lips and the floor of the mouth. The throat, which is divided into the nasopharynx, the oropharynx, and the hypopharynx from top to bottom. The larynx, so the throat itself, and the nose, the sinuses, and the salivary glands. All are included in head and neck cancer. Important risk factors are, as we know, smoking and alcohol, and those two strengthen each other as well. So if you do both, the chance of head and neck cancer increases exponentially. The humane papillomavirus, or HPV, which we also know from cervical cancer, and other factors like bad nutrition or deficiency in certain vitamins, the chewing of tobacco as well, which is more common, for example, here in the northern Scandinavian countries, bad oral hygiene, or more specifically things that are more locally known in, for example, Southeast Asia, the chewing of the betel nut, which you can recognize with the people have the orange teeth. This is also so. I previously mentioned that the incidence of head and neck cancer, but it varies along the world. So for example, in India, the incidence of head and neck cancers is much higher than it's over here. But you can in general say that it's in the top 10 of types of cancer worldwide. Most of the head and neck cancers are squamous cell carcinomas, and the others are lots of different types of cancers, which I wouldn't go into right now. The medical intervention regarding head and neck cancer is dependent on the tumor size, which is also expressed in the TNM score, and the lymph node involvement, which is expressed in the same TNM score, and can consist of surgery. Here you see a patient with a typical scar on the neck, most of the times involved in a neck dissection surgery. You see a radiation mask. Lots of people undergo radiation therapy. And you see a systemic therapy, which can evolve like chemotherapy or immune therapy, which is gaining more ground in specific types of cancer. Let's see. The physical therapy treatment indications that I want to elaborate on are limitations in the shoulder and neck function, a reduced opening of the mouth, which is also known as a trismus, and a general reduction in strength and endurance. And strength, you can split that into lower and upper body strength, as I did in my study, and endurance, which I measured, for example, with walking ability measured with the 6-minute walking test. There's also other measurements on, for example, mobility. Of course, there are lots of other physical therapy treatment indications, different indications involving limitations in oral functions, as for example, chewing, which Caroline Specksnyder did a lot of research into, but also lymph edema, facial paralysis caused by the treatment of the head and neck cancer. But as you can see in bold, these are the three I want to go a little bit more specifically into. Let's see the subject of shoulder problems. Lots of shoulder problems are correlated with the performance of neck dissection. Neck dissection surgery is almost is a big part adjacent to primary removal of the primary tumor. So for example, say if you have a tumor of the tongue and it's removed, and sometimes the lymph nodes are involved, or there is a high risk of lymph node involvement, and then the surgery can be completed with a neck dissection surgery in which the lymph nodes at risk are removed, or the lymph nodes that are have metastases in it are removed. And the extent of the neck dissection is always mentioned or noted with the amount of levels in which the lymph nodes are removed. So here you see the numbers of the levels, and the more levels that are cleared of lymph nodes, the larger or the more extensive the neck dissection is. And in lots of cases, the more extensive the neck dissection is, the more complaints are to be expected. And an important aspect of that is also if the accessory nerve that is in this field, as you can see, it's here marked with the yellow line, if there's damage to this nerve, or if it's even resected due to tumor involvement or lymph node involvement. Damage to the accessory nerve can cause problems with the muscles it innervates, and that in this case that can be the trapezius muscle. And in the next slide I can show you a bit of what you see, what the clinical image is for patients with accessory nerve problems or loss of function due to accessory nerve paresis. You can see here that the trapezius muscle is not functioning well. And more important, that function of the shoulder in forward flexion or shoulder abduction, in which the stabilization of the scapula is very important, which you see over there. With a lack of trapezius function, there's a problem with upward rotation of the scapula. So the patient is not able to perform movements of the forward flexion, the shoulder abduction above the 90-degree range of motion. This can be very causing a lot of problems in daily life, especially with functions above the shoulder, and it requires extensive rehabilitation. Let's see, that's enough for this movie. Research we previously published showed that older patients and patients with a more extensive neck dissection and with more extensive reconstruction surgery had more problems. I won't go into all the details of this figure, but this figure shows shoulder abduction and forward flexion on the left in degrees, and the 4 measurements or 5 measurements we performed on baseline, 6 weeks, 6 months, 12 months, and at 5 years. And what you see is that almost all patients experience a loss of range of motion in the first phase after surgery, so at the 6-week measurement. But the patients with little risk factors, there's less extensive neck dissection and less extensive reconstructions, have a less deep dip and almost recover, especially when you correct it for the normal decline in age. But there are certain patients that are at risk. And those patients, in our opinion, should be identified and treated with physical therapy. So that was it on the shoulder subject. The neck or the cervical spine is also very important. We see a lot of patients with bad posture. Most of the treatment is on the front side of the neck. So patients experience a little bit of a stretch on the front side. The surgical scar is on the front side. Sometimes the patient had a stoma after surgery. All the pulling force is to the front, so it impacts posture and impacts mobility and function, as well as of course pain and everything involved with the treatment. It's not only surgery that impacts the cervical functions, also treatment with radiotherapy. Here you see a very extensive case of a reaction of the skin on radiotherapy. As you can imagine, it looks like inflamed, it's painful, in the long term it can cause fibrosis of the tissue. So a lot of survivors of head and neck cancer and patients after treatment experience problems with the cervical spine and mobility of the cervical spine. Not only mobility, we even see patients, and this is something I discovered lately, and when I checked for it in literature, it was reported more often, but you see here on the left little twitches, almost like little spasms of the neck, possibly caused also by nerve tissue damage. So we have the direct damage of the radiotherapy, we have the nerve damage, the skin damage. Let's see, that's not another time. And combined, it can cause big problems in the movement and the mobility of the neck. Here you see a patient after 2 years after treatment, both surgery and radiotherapy. And you can see how limited the range of movement is when you see lateral flexion of the neck or rotation of the neck. You can see the almost like bands stretching. That's a combination of surgical treatment, the mobility, the treatment related mobility caused by the surgical treatment, and by the radiation therapy. The third topic I wanted to discuss was oral function, and one specific oral function. And most of the times here I present somebody with a trismus, as it's the definition of a limitation in the maximum opening of the mouth. But at that moment, I would like to see what's the maximum opening of the mouth. It's more like a little gimmick, but a trismus is everything below 35 millimeters, but the world record for the biggest opening is used to be a German record with 88 millimeters, but of course the United States performed better. So the current world record holder lies in the States with 95 millimeters. I tried that. A very easy to use tool in the physical therapy practice is just to see if you can get 3 fingers between the upper and the lower teeth to decide if it's a trismus, or measure with a tape measure. That's what I did. And everything below 35 millimeters is regarded as a trismus and should need some attention. When we look at trismus, so below that cutoff value, it's quite often present in survivors of head and neck cancer, especially when the primary tumor was located in the oral cavity or in the oropharynx. Research performed by Jan Willem Wetzels and also Caroline Specksnyder found that risk factors for trismus, as you see here, also the big dip at 6 weeks post-intervention and slight recovery, but the risk group at the bottom, they identified that radiotherapy and a preoperative trismus, so a limitation already existing before intervention, and not so or a location of the tumor that is near to the joint or involves, for example, the masseter muscle, are risk factors for a trismus at the post-intervention setting. Here you see bad types of location or risky locations. So here you can see the tumor located in the cheek, the side of the cheek. Here a schematic picture of a salivary gland, a parotid tumor, which is also near to the temporomandibular joint. And here you see a tumor just at the point where the upper and the lower jaw meet, or what we call the trigonum retromolare, so behind the big molars. As you can expect, after surgery, this is a not so good location for the development of a trismus. So that you have to keep that in mind as you have a patient and you see the notes which you get from the doctor or from your colleague in the hospital, that this patient might have a greater risk on development of a trismus. Strength and endurance, or as I measured lower and upper body strength, it's a very vulnerable group, this head and neck cancer patients. As you can see in the risk factors, it is a little bit of a special group as well. So there's a higher risk that they already have a lower level of physical activity, and correlated with that, a lower strength and endurance. And maybe also reduced mobility and walking ability, and that's something I researched as well. And with that, I think I now presented a bit of the main problems as experienced, or you can face when you treat patients with head and neck cancer. So I would like to take that information together and present something on the research I did. I performed research on 50 survivors of head and neck cancer, which I measured with something you can call a core set of measurements involving maximum opening of the mouth, as you can see here with a little cardboard card, cervical mobility, as measured with a cervical range of motion measurement tool, shoulder mobility, as measured with a digital inclinometer, hand grip strength, and lower body strength as measured with the 30 seconds sit to stand chair test, level of mobility as measured with the timed up and go test, and walking ability as measured with the 6-minute walking test. These tests I did to measure limitations, and I also asked these survivors to fill in some questionnaires, and also these 2 supportive care needs surveys, which you can use to identify unmet needs. There's one cancer generic unmet needs survey. This is the SNS SF34, and there's also a specific head and neck cancer module, which you can use to identify specific unmet needs in regard to head and neck cancer patients. How did my research group or the people I studied look like? I included two groups. I included one group from the Patient Federation, the Dutch Patient Federation for head and neck cancer patients, and I included 33 patients at the follow-up here in the hospital where patients visited the doctor. Why two groups? Because the Patient Federation in the Netherlands consists of a lot of laryngectomies. So if I would only use Patient Federation members, the group would not be representative of the total head and neck cancer population. As you can see, it consists of quite a lot of females, especially in the usual care follow-up, which is not typical for head and neck cancer. I'm not really able to explain this, only possibly with a volunteer bias, with females being more willing to participate. Age and body mass index indicate that the people who were involved in my research are a little bit overweight, with a body mass index of above 25, a median body mass index of above 25. Most patients were survived from a few years after treatment, and the location of the tumor varied. As I explained before, the Patient Federation group consists of a lot of laryngectomies, and the usual care follow-up group had way more oral cavity patients in it, which combined makes them more representative of the total head and neck cancer survivor population. The interventions varied, as you can see here. Okay, this is a big table, so it's against the rules of PowerPoint, but I'll take you into it. At the left, you can see the limitations that we measured for this group, so the total group of 50 survivors. And what we did is that we compared all these outcomes to age and sex stratified reference values. So we had age and sex stratified reference values for all these range of motion measurements and from opening of the mouth. And then we compared which percentage of those reference values was scored by each participant. If a patient scored 80% or less compared to these reference values, it's in this column over here. So 8 patients scored 80% or less of the reference value, and 3 patients scored 40% or less. We're a little bit arbitrary, but we use this to find patients who had limitations that we regarded as in need for physical therapy. As you can see here, most scores are quite high. So when you have a mean or a median score of over 100% of the reference values, this would indicate this group B research was a lot better than we expected. But still, we could identify patients that were below the reference value and might benefit from physical therapy. And these are the patients we compared to patients who also expressed unmet needs as measured with the previously mentioned supportive care needs survey. But here you can see range of motion and maximum opening of the mouth. It was not as high as we expected in this group. Same limit of other limitations. So here we see hand grip strength, level of mobility, walking ability, and the more specific limitations and cancer generic limitations altogether. But let's look at the top 3. Then you see that here we had a bit more survivors that scored way below reference value. So 15 patients had hand grip strength of 20% or low, of 80% or lower compared to reference. And with walking ability measured with the 6-minute walking test is even 35 out of 50. So lots of people performing worse than we expected. When you combine these things, so the more generic depicted over here, or the more head and neck specific, 85% of the patients expressed at least one head and neck cancer specific limitation, and 67% of the patients experienced at least one of the more cancer generic limitations. Then our question was, do these patients also express unmet needs? So here you can see the outcomes of the more generic questionnaire on unmet needs and the head and neck cancer specific questionnaire on unmet needs. Let's go directly to the domain score. So the generic questionnaire has a lot of domains, but I'm very interested in the physical and daily living domain, of which you can see the 5 questions below this title. But in the domain, at least 24 patients experienced or expressed one unmet need. And when we look at the more head and neck cancer specific questionnaire, of which especially 2 questions were very interesting for physical therapy, so problems with chewing or swallowing, which indicate problems with mouth opening as well, and problems with the mobility of the neck and shoulder, which, as I expect, is very interesting for the physical therapist as well. We can see that at 46% of the survivors expressed at least one unmet need in these 2 specific questions. So this is, in summary, we see patients with limitations and we see patients with unmet needs. But the question is, do these 2 associate? So if a patient experiences problems with active range of motion of the shoulder, do they also express an unmet need with the questionnaire? So are these 2, can they be compared, or can you use just one of them to find the patients you need to find as a physiotherapist? No, there was no association at all, only one small association between the domain score of physical and daily living needs and lateral flexion of the neck, but it's only a small association. It is significant, but it doesn't mean that much because we don't find it clinically relevant. So it was a little bit of disappointment, of course, but we think maybe both measure a different construct. And it's not to be said that the patient that has a need also has a limitation and the other way around. And it leads to a lot of new questions, as for example, should we measure the survivors during follow-up with physical performance measurements, or do we use the questionnaires? This research led to a lot of new questions, as usual in research. And then for the last bit of research I want to present, I hope it's quite a new subject, but all the measurements we performed during this research, we performed twice with a break in between, of course, to see if they were reliable, retest reliability, and if they showed agreement. So here again, you see the different measurements we performed. And in general, the intra-class correlation coefficient of all measurements was good. So, which you can see here in the first column, most of them are above 0.7 or 0.8 or even above 0.9. So retest reliability was good. When you're looking at the agreement parameters, like the standard error of measurement or the smallest detectable change, these are quite hard to interpret when you don't have anything to compare them to. So we use the smallest detectable change percentage, which compared the smallest detectable change to the average score. So how many percent of change do you have to measure to be above the measurement error? So that makes all the tests comparable. And then you can see that those numbers are quite high. A change score of at least 33.7% with the CROM device is a lot of change to measure to be above measurement error. We published this data and these results, and you can see them again for the other measurements we performed, and you can still see that those ICCs are very good, but that the measurement error, the level of agreement as measured with, as expressed with the smallest detectable change percentage, is quite high. What does this mean? That as a physical therapist, you'll be able to reliably discriminate between survivors performing good and bad. So test retest reliability is good, or good to excellent as measured in our research. There are a few tests, like the tests we use for maximum opening of the mouth, forward flexion of the shoulder, and the 6-minute walking test, that show relatively small measurement errors expressed in those percentages. And so they can be used for evaluative purposes, but the other measurements have to be used with care when you use them in evaluative purposes. I think I'm right within time. So I think it's, if there are any questions, I don't know if that's at this moment or after all 3 presentations, I would be happy to answer them.
Thank you, Gerben. This was wonderful. I really like how you were able to look at the holistic picture of, you know, movement and walking. We spend so much time, or we used to spend so much time as physical therapists just concentrating on the direct area, but it shows how people who have gone through head and neck cancers have so many other limitations, you know, even, you know, with the walking and the shoulder function. So this is really important work, and thank you. I imagine that we're going to have John speak next, and then we'll have some time at the end for more discussion. Is that fine with everybody?
Fine with me.
Okay, so thank you again, Gerben, and we'll be talking more at the end. So John, it's time for you to present your slides and your presentation.
Go ahead and share your screen, John. Okay, so I'm not seeing John on the list of people that are on right now. So I'm not sure what happened to John. Are you there? Lisa, would you like to go ahead and go on?
Sure, I can do that.
Thank you. Hopefully John will be able to join us.
Yes, he was here, so.
He's not showing up on the screen, Jackie. Oh,
Oh,
there he
there he
is.
is.
Okay. John, would you like to go ahead, or Lisa, do you want to go ahead? Who's up next here?
I'm happy for John to go ahead if he's ready.
Okay. John, are you with us?
It looks like he's in the waiting room.
I'm letting everybody in. I thought I already let him in, but
He might have had to exit for a moment.
right. He's trying to join us right now. So it must be a connection thing.
Okay, well, in that case, if you prefer me to, I'm happy to go.
I think so, Jackie. It's up to you.
Is John trying to get in right now?
Yes, ma'am.
Well, maybe give him just another minute. Does anyone have any questions for Gerben?
There you go.
Hi, how are you doing? I'm a physio in Cork in Ireland, and we treat pretty much 90% of the head and neck patients in the south of Ireland. Just a quick question: do you use much photography for showing patients' development and increased range?
Yes, we especially with like shoulder rehabilitation, so specific accessory nerve problems, we take video footage and we collect it at every consultation, so we can show patients if they improve, especially with like tough rehabilitation programs with shoulders, with coordination exercises, scapular stabilizing exercises. It's quite hard to teach patients those motor control techniques, so we use a lot of video footage to show them, and mirrors and everything involved.
Yeah, and do you use any like there's a great app that we use for measuring, it can screen grab and measure angles of shoulders and rotations that we've started using for the last 6 months. Have you gone into any digital, because obviously those head inclinometers and the shoulder inclinometers, they're not, they're very hard to use, especially with COVID.
Yeah, I think it's a great idea. I think it's a great idea to use, but we didn't use them yet. No.
Okay, that's something we started using. We're just looking for a bit of research out there to see
if it's reliable,
validity and reliability.
Yeah, and I understand. I have no personal experience with the apps, but if you find anything, I would be happy to receive.
I'll type in the name of it. It's a single app there. It's free. It's on all Android. It's a really good one. And what we've done is we've created like a template of pictures that patients take themselves. They email it in, and we get the measurements, and then we try to.
Victor,
yes.
Is it possible for you to put a link in the chat?
I have just typed it in there. It's called Image Meter.
Okay.
It's a very it's free. It's a great little app that's free. So for head rotation, we take a picture looking straight down on the head. For side flexion, obviously, and we can. We just made up a little template sheet that we give to patients going home because of COVID. We can't bring them into the hospital, and they email us every 2 weeks, and we see progression. Or
good.
It's just a nice, easy one to do.
Yeah.
Okay, thank you. This is Jackie again. Liisa, let's have you go. It sounds like John, or it looks like John is having trouble getting on, so we'll have you go next, and then hopefully John Davidson can join us then.
Sure thing.
All right.
Let me just find my. Okay, can you see that?
Yes, I can. It's beautiful.
Excellent. Okay, I'm just going to put my timer on so that I don't run over too much over time. Look, I just wanted to say good day to everybody from Australia. It's about 20 to 9 at night here. And whilst I'm saying hello to everyone, also to thank IPT-HOPE for asking me to present on this panel tonight. This is where I live in Australia. I live on the Gold Coast, which is between Brisbane and Sydney. And I work up the road, up the motorway, about 70 kilometres at Marta Research, which is, just get rid of that person there, which is, my office is in this lovely old building, which is 110 years old, heritage listed, and it sits in behind all these other newer buildings that have been built since in the last century. Can I pass on my best wishes to everybody around the world? It's been a dreadful 12 months. We think we have it bad here from time to time with some border closures from time to time, but we have it nowhere near as bad as people do elsewhere, and our thoughts are with you all. So what I wanted to do tonight was talk to you about oral mucositis, and and specifically about photobiomodulation or light therapy, or some people call it low-level laser therapy or laser therapy. It has a number of different names, and tell you what the evidence is around this, as well as touch on some of the other cancer treatment-related toxicities and side effects of head and neck cancers as well, which have been found to have some benefit in relation to management and treatment with photobiomodulation. So what is oral mucositis? I'm sure that most of you do know, but I'm going to zip through this. It's a common complication of radiotherapy and or chemoradiotherapy in head and neck cancers and in hematological cancers. It also occurs in other conditions such as non-small cell lung cancer. It's a dose-limiting toxicity in cancer treatment. And for those people who it does occur in chemo-induced oral mucositis, it starts at around about 5 to 10 days after the commencement of chemotherapy and lasts for about 3 to 12 days if everything goes to plan. And in radiotherapy-induced oral mucositis, it starts about 2 weeks after commencement of radiotherapy and can last anywhere from 3 to 12 weeks. The severity, I'll come to in a minute how that's graded, but it can occur in up to quite a significant percentage of patients, depending on the publications that you read. In about 2/3 of people, it can be quite a severe grade. And oral mucositis is more common among patients with oral cavity or oropharyngeal primaries, those who've received chemotherapy, and those who are treated with altered fractionation schedules. The pathophysiology is fairly well defined now. There's an initial injury to the cells by radio or chemotherapy that results in direct DNA damage or through the inflammatory process. That results in tissue damage and the release of inflammatory cytokines, a few of which are listed there: TNF, tumor necrosis factor alpha, interleukin 1B and interleukin 6. And that inflammatory process and the tissue damage can result in a vicious cycle of inflammatory cytokine mediated damage. Eventually though, if things are left to go according to nature, there should be healing and re-establishment of the mucosal barrier. In the meantime, though, the problems can be quite significant. I'm sorry, is someone talking? Okay, must have been some interference. So this is an image of what that continuum of damage looks like from the normal epithelium through to phase 1 or initiation of the damage from radiation or chemotherapy, eventually to ulceration of the mucosa, and hopefully to healing eventually with fibroblast proliferation. The symptoms and sequelae, symptoms, it's characterized by redness and ulceration and pain. And in some people, that can predispose to septicemia, particularly in those people who remain neutropenic after chemotherapy. And in a number of people, about 5%, the patients with oral mucositis can have significant weight loss and significant pain. And this is what it looks like in a clinical setting. The mild grade 1 has got soreness and erythema, and that gradually can become problems with ulceration and where oral feeding is not possible because of all of the problems associated with oral mucositis. The current treatment is really basically symptomatic treatment, obviously comprehensive oral hygiene and regular mouthwashes, good oral hydration, and avoiding the things that can make the pain worse. acidic foods, spicy foods, salty foods, etc. Avoiding alcohol and tobacco, and using ice cubes or water-based moisturizers. From a drug perspective, and of course all of those will result in reduction in quality of life. From a drug perspective, painkillers, non-steroidal and inflammatory drugs can help, and antibiotics if there's an infection. For severe grade oral mucositis, grade 3 and 4, parenteral feeding may be necessary, and gastrostomy or jejunostomy may be necessary as well, depending on how badly the oral mucositis has affected the upper parts of the gastrointestinal tract. And of course, all of that results in increase in costs. The patients will have symptoms that affects their quality of life. It results in some people spending weeks in hospital, and there are costs associated with that in terms of the burden of care and out-of-pocket costs, and the facility costs in terms of bed days, etc. So if we can do something that will benefit the patients, then both patients and the facilities will benefit in a reduction in costs and an improvement in quality of life. If we talk about costs briefly, parenteral nutrition costs, if we look at that in New Zealand dollars, if there's anyone attending tonight from New Zealand, some work has been done in this space, and people outside of intensive care, it can cost $251 a day for parenteral nutrition, and given that return to oral nutrition is achieved in only 57% of patients within 12 days of commencing parenteral nutrition, that's 3,000 New Zealand dollars in that period of time. So it's not an insignificant problem. If we look at it in US dollar costs, the difference or the differential between people who have mucositis or pharyngitis and those without mucositis, that differential in terms of median medical cost per patient is over $18,000. And, it can cost something like $12,500 for hospitalization for a median admission of 14 days versus 5 days. Again, in US dollars, but this is a study that was carried out in the UK, the incremental cost of mucositis-related hospitalisation is quite significant in people who've had stem cell transplant, and the serious or long-term outcomes of oral mucositis are the major drivers of cost. So it would be important to be looking at what's possible around reducing the incidence of this particular problem. And that's where prevention is probably something that photobiomodulation can provide as an alternative, as much as a treatment for those people who have oral mucositis. So what is photobiomodulation? What is PBM? It's basically light therapy, and because I'm speaking to physical therapists, physiotherapists, you would remember from your university days that we have an electromagnetic spectrum from radio waves through to gamma rays, and in the middle of that spectrum is our infrared and visible and ultraviolet light waves. This near infrared and visible part of the electromagnetic spectrum is where we see photobiomodulation therapies situated. The history of light in physiotherapy and the evidence-based use of light in physiotherapy is really very long. It's more than a century, and some of you will be familiar with Niels Finsen. He was a medical doctor who devised an apparatus to emit blue light to treat his patients who had TB-related dermatological conditions, and that blue light had really good effects, and he won a Nobel Prize for that discovery and the use of light in dermatological conditions. We know that light is used in lots of different circumstances, in neonatal jaundice. And of course, if you've been to a doctor, to a dentist recently, you'll know that they use light for curing fillings and for treating pain and reducing inflammatory reactions to their therapies. Light is therapeutic. We've known that for a very long time. Photobiomodulation is specifically researched, and the mechanism is its effects on the mitochondria of cells. And as the light affects the mitochondria release ATP, reactive oxygen species, and nitric oxide, which then have an effect on the cell signaling pathways, which can then really have an effect on gene transcription, growth factor production, and a number of other effects. So I equate PBM, photobiomodulation, and the different wavelengths that can be used with drugs. The different intensities of PBM I equate with the dose of drugs. So if we think about this very briefly in terms of the effects of photobiomodulation, this was work that was done recently by colleagues in the USA who were looking at the effect of light on bacterial substances. And you can see here, compared to control, that if you use ever increasing doses, then the bacterium affected and reduced in the colony size and number. Equally, if we look at photobiomodulation from the perspective of wound healing, and in this case, epithelial wound healing, you can see that re-epithelialization using photobiomodulation occurs much quicker compared to control in day 3 and day 5 compared to control. So we can get a faster effect on wound healing by using photobiomodulation. And then for the pain that may be associated with oral mucositis, there's plenty of studies that demonstrate that different wavelengths of light will have better effects on inflammatory pain. And this was done in the rat study. This is work that we did back in the early 2000s. So PBM has the capacity to do a number of things in different situations and upon different cells. So that's as much as I'm going to say about PBM for the moment. What we need to do now is look at the evidence of PBM in oral mucositis. Now we know the different tiers of evidence, and we know that the clinical practice guidelines are at the top of that. Oh, what's happened to my arrow? There it is. We know the clinical practice guidelines sit at the top of that pyramid of evidence. And it's important to note that the evidence for PBM in oral mucositis is at the top of that pyramid. The National Institute for Health and Care Excellence in the UK has released this guidance about the interventional procedures of using low-level laser therapy or photobiomodulation for preventing and treating oral mucositis caused by radiotherapy or chemotherapy. The number needed to treat is 3 to prevent 1 case of severe oral mucositis. Now that's absolutely amazing that you only need to treat 3 people to be able to prevent 1 case of severe OM. And the studies using intraoral laser therapy have reported a larger reduction than those that have used extraoral laser therapy, but that's much better than not treating oral mucositis at all. And the symptom reduction is better where larger energy is used, larger doses is used, greater than 4 joules per square centimetre compared with less than 4. If we look at the slightly lower tiers of evidence and the information that fed into those NICE guidelines. This was a systematic review and meta-analysis carried out in 2019 by Ansho and colleagues, and they concluded that there's moderate evidence that laser has an effect in resolving, so treating oral mucositis in adult patients, and that there was a potential for decreasing the resolution time by approximately 4 days. So if you can reduce the time that patients are spending in hospital with oral mucositis by 4 days, that reduces the costs involved and hopefully improves their quality of life once they start to feed orally again. For those who like to see the forest plots, this is from that same study. It's very clear that the results favour light therapy in adults, not so much in children. The research has not been done sufficiently well or in number in children to say that it will help children, although I'm aware that at the Melbourne Children's Hospital here in Australia, they are using PBM for children with cancer treatment-related oral mucositis to prevent and treat that. For the chemo or chemoradiotherapy induced oral mucositis, the evidence is also very clear from the forest plot that it favours laser or PBM photobiomodulation in the treatment and prevention of that condition. This is another systematic review just to demonstrate that this is not limited to just some groups of authors. This is from the Mucositis Study Group of the Multinational Association of Supportive Care in Cancer in consultation or collaboration with the International Society of Oral Oncology, and their guideline recommends the use of intraoral PBM for preventing oral mucositis in adults receiving radiotherapy to the head and neck without chemotherapy. They also recommend the use of intraoral PBM for the prevention of oral mucositis in adults receiving radiotherapy and chemotherapy for head and neck cancer. They recommend the use of intraoral PBM in the prevention of oral mucositis in adult patients receiving stem cell transplants who are being conditioned with high dose chemotherapy with or without total body irradiation. And I guess the important thing here is that there were no short or long-term adverse events that have been reported. And there was one cohort where 15% of patients experienced an immediate but non-painful burning sensation after red wavelength of laser treatment. Moving on, this is from Zeka and colleagues. Many of those names have appeared on the previous publications that I've presented in the previous slides. This particular article gives us some information about the actual protocol for use of oral mucositis. And you can see there I've highlighted in the second column that you can use photobiomodulation for its prophylactic effects in chemotherapy and in radiotherapy. And basically the idea is to start on the first day of either chemo or chemoradiotherapy or the day before, and to continue treatment at least 3 times a week if the treatment is for therapy or treatment of oral mucositis. You can see in the diagram here in the middle, the recommended areas to treat are the lips, over the buccal mucosa, and at the front of the neck along the lymph glands, and if treating intraorally across the tongue and at the back of that back there at the pharynx. The device characteristics are fairly broad. You can use anything in the range of red through to infrared wavelengths to do this work. And the dosing, as I mentioned earlier, for prophylactic work, something in the notion of 2 joules per point. For treatment, at least 4 joules per area of irradiation. And if you're applying it extra orally, as in this diagram here, then around about 3 joules. And the areas, as I've already mentioned, the target areas are listed there on the right-hand column. So lastly, in the last few minutes, I want to talk about the other effects of photobiomodulation in cancer treatment-related toxicities, and talk a little bit also about the safety. I have already mentioned that briefly, but I do want to look at that in a bit more detail. So this is work that's been done by colleagues, photobiomodulation colleagues in Belgium, and they've been looking at the use of photobiomodulation for treating or preventing radiation dermatitis. And they've gone on to publish that full trial, concluding that the results showed that photobiomodulation is able to prevent the development of grade 2 and higher acute radiodermatitis, and it also reduces the patient's symptoms. Other authors have also been doing this work in trying to manage radiation-induced dermatitis, and they've come to the same conclusion that photobiomodulation using light-emitting diodes applied prior to radiotherapy may decrease the incidence and sequelae of radiation-induced skin toxicity. Most of that work has so far been done in breast cancer patients, but I can't see any reason why it couldn't be done in patients who have and who are receiving treatment for head and neck cancer. For pain and swelling, basically related to lymphedema, again, most of the work here has been done in people who've had or been diagnosed with breast cancer and had treatment in a systematic review and meta-analysis. The parameters that were most commonly used was at least 17 minutes of treatment using a 904 nanometer wavelength 3 times a week for 3 to 4 weeks with quite a low dose, and that is applied to the axillary region. And in addition to that, other researchers almost 20 years ago now found that 2 cycles of treatment of 3 to 4 weeks rather than just 1 cycle is better at reducing limb volume, reducing extracellular fluid, and reducing tissue hardness. And then from a pain perspective, from a chemotherapy-induced peripheral neuropathy perspective, there's not been a lot of work in this area. This was one published paper that has come out in the last few years where they found that sham treatment with photobiomodulation did not reduce pain, but various parameters, various combination of parameters of photobiomodulation can significantly reduce the symptoms of neuropathy. Lastly then, just a quick note about safety related to photobiomodulation use in cancer. This is a systematic review of 27 studies where they looked at the use of photobiomodulation in oral mucositis, lymphedema, peripheral neuropathy, and radiodermatitis. And they found that the use of photobiomodulation therapy in the prevention and management of cancer treatment toxicities does not lead to the development of tumour safety issues. So I think we can be comforted by that information at this point in time. What I do want to point out, though, is that nothing has been done in the area of fibrosis and tissue hardening. And I think this is something that we do need to be thinking about in terms of the longer term sequelae of cancer-related toxicity, cancer treatment-related toxicity and the long-term effects, and the potential of whether we treat mucositis and tissue damage better in the early stages to help to prevent fibrosis. A colleague of mine in the US, Matt Morrissey, and I, and a colleague of an oncology colleague of his, we've just completed a narrative review around the kinds of treatments that may be suitable or have been tried for long-standing fibrosis, and we're currently trying to get that published. So I won't give away any more information at this point in time. One last slide to bring us back to head and neck cancer. This was a study that was looking at the responses of low-level laser therapy or photobiomodulation therapy on different cells that are typically found in head and neck cancers. This was an in vitro study. It looked at red wavelengths of light, and they found that in human oral squamous carcinoma cell lines and non-malignant epithelial cell lines, there was a reduction in cell proliferation. There was also a pro-apoptotic effect in the squamous cell carcinoma line and an increase in fibroblast proliferation, which is really interesting that in one bad cell line, if you like, the cancer cell line, that light therapy can cause destruction of the cells, yet stimulate good cells in terms of the healing process. So that's really important evidence around the safety of PBM in cancer. And the other point to note there is that there was no tumour promoting effect in that study. So I wish to thank you very much. And I think I've managed to finish just on time.
Thank you, Liisa. This was just excellent. I'm going to have John set up, but while John is setting up, there was a couple questions in the chat box. And one for Liisa is, are there certain brands of devices that you would recommend?
Oh, there are a lot of brands. I think the important thing to look at is what is your, what's the makeup, the profile, your patient profile, and what do you treat most in your practice, whether it's in a hospital setting or in a private practice, and understand what it is that you're, what the cells are, what the conditions are that you're targeting, and then work out from there what wavelength you need and what power output you need. So for example, if you're treating mostly superficial tissue healing, then a red wavelength at a reasonably low power output is going to do the job for you. If you're treating deeper musculoskeletal kinds of problems, then you probably need a wavelength that's going to penetrate deeper into tissue, something in the 800 to 900 range of wavelength, and probably will need a higher power output as well. I'm happy to take that conversation offline with someone if they wanted to give me send me an email.
All right, that was from Jillian Buckley.
Oh, hi, Jillian.
We will discuss, we'll have more time at the end to discuss some of these items too. So let's have John open up his presentation. And thank you so much, Liisa. This was just excellent.
You're welcome.
All right, we're waiting for John's presentation to come up.
Go ahead and share your screen, John.
You have to make me the co-host so that I can share the screen. Who's the disabled participants screen sharing?
Okay, I just made you co-host again.
Okay. My network was bad and I was out of network. Thank God I'm back. Thank you, Anne. Thank you, Jackie. And everyone.
John,
So,
John, your voice is breaking up a little bit. I don't know if you can speak into the microphone a little better. And I so appreciate you being here, and sorry for all these technical difficulties we're having. If you could try again. I don't know.
can you hear me better now?
It's breaking up still. Anne, is there anything we can do to help?
It's my network.
Yeah, it says network.
Oh,
Yeah.
And so, John, just go through your slides perhaps, and I can help you narrate them. Okay.
So,
And so John is at the University Teaching Hospital in Nigeria. And he is very active in working with people with head and neck cancer. And we want to hear from you. I'm not sure how to clear up your, I'm not sure how to clear up your screen and your sound. But go ahead and proceed, and maybe you can type into the chat what you would like to say, and we can see what you would like to say. And so to start, I see that you're defining the terms palliative care. And many times we overlook the area of palliative care. And it is part of the continuum of cancer care. John, do you want to type anything into the chat that you'd like me to highlight for you? Hospice is also a portion of supportive care, and we know that it's usually meant for people less than 6-month life expectancy. However, the idea is to give people a longevity with as little pain as possible. In the US, more than 6 months may be something that we see quite often, and people tend to go into and out of hospice care intermittently. And so John has left. John, have you left us? Okay.
Patients with lymph edema, I answered in the chat already. So most patients at risk for lymphedema are the patients, as I see them here, with the bilateral neck dissections or with extensive radiotherapy and surgery intervention. And we are still lucky that all of the physical therapists here are allowed to see patients, for me as well. And so all the lymph edema specialists, physical therapists or specialist treaters are still able to consult these patients. So we don't have any problems with referring them or treating them. Did that answer the question?
I think so. I don't know if Kristen or others Jillian would want to have any other comments or questions. Does anyone have any other questions they have for Gerben right now? Okay. And would we like to try to get John back on?
Hi, everybody. Let's see.
It's sunny over here. It's
Oh, first off, our panelists, we are going to be giving them the International Scholar Award from the IPT-HOPE. So Nina Chekbo will be sending that to you, Gerben and Liisa, and then John, as we get his presentation up. Your information is so valuable to us internationally. And then the other thing, we will be having another presentation on pediatric cancers in May. There's a speaker from the United Kingdom, Abu, and a speaker from Colombia, Pia Delgado, who are going to be coming and speaking about pediatric cancers. The other thing I want to highlight is something that Caroline's been working on for the and for the upcoming networking session within the World Congress. We're going to have an IPT-HOPE online networking session. And what we'd like to do is have breakout sessions for each of the special interest groups. So right now we have HIV/AIDS, we have oncology, we have lymphedema, and we have hospice and palliative care. And what we'll do is we'll have, I think we have about a 45-minute networking session. And what we'd like to do is develop the networks within the special interest groups. So the other thing we're hoping to do is that we have liaisons from our member organizations. And right now we have 13 member organizations. And we're trying to populate these special interest groups. So we want people to join the special interest groups, and that way we can advance our work within these important areas, you know, of our IPT-HOPE network. Anne, do you have any comments about what's coming up with the networking or with the education or what we're working on?
No, I think you covered everything very nicely. We really appreciate everybody. And the only thing I guess I do have one other comment. Victor is asking about informal discussion groups. That will be part of the SIG special interest group when we get together during WCP conference. And so if you're interested in a special interest group, we will do breakout sessions, as Jackie mentioned, and that'll be a great opportunity. Caroline will be working with people on getting that all together. So thank you all for all your hard work, and thank you for joining us today.
Yes,
stay safe, stay warm.
Yes, I appreciate everyone coming and all these odd hours and, you know, the internet connectivity. One of the things we are thinking about too within the IPT-HOPE is having the education sessions, but also beginning to have networking sessions within the special interest group. So we can have online global networking sessions for people to come and just talk about what's happening. And it's amazing how people from around the globe are doing similar things as physical therapists with all the problem solving we have to do related to COVID and all the support that we're giving each other. And so even though we're learning from each other, we're also seeing how a lot of us are doing similar things with our practice and having some of the same challenges and problem solving capacities. So it's amazing that this is such a wonderful group of people that are using their skills and their critical appraisals to advance practice and care for our patients. And I guess that's really what I'd like to end on here. Does anyone have anything that they'd like to add at the end here? Any further comments?
Thanks for organizing.
Oh, you're very welcome. Thank you for speaking. This was so wonderful. All right, then. Well, then I'm going to bid everybody a good morning from the frozen Michigan. We're below zero here, and I'm jealous of people that are in warm, sunny afternoons. I'm speaking about you, Imad.